Hello, I'm Taylor Sisk. Welcome to session 4, Developing a Rural Healthcare Workforce. As has been well documented, we have a significant shortage of healthcare professionals in so many rural communities across the country. We've long known that healthcare professionals who were born in rural communities are more likely than those who are not to end up practicing in rural communities. But data now also indicates that those trained in rural communities are also more likely to set up practice in those communities. The folks we have on our panel today are making significant contributions to facilitating the education and the training and the preparation in general that allow health professionals to confidently and comfortably arrive in rural communities. With us are Janelle Sokolowicz, Associate Provost for the Social Mission at Chamberlain University. Brian Hodge. Brian is Chair of the Department of Community and Public Health at the University of North Carolina Health Sciences at MAHEC. And Emily Hawes is a professor in the UNC's Department of Family Medicine, and she serves as Deputy Director of the Rural Residency and Teaching Health Center Planning and Development Programs. Our guests will share their insights and then answer your questions. You can ask questions at any time by typing them in the Q&A window. Please put them in the Q&A window and not in the chat. The chat is for you to interact with you and for you to interact with one another. So I'm going to first ask our panelists if they would just tell us a little bit about themselves, who they are, their roles, and the communities they serve. And I'd like to start with you, Janelle.
Hello, everyone. I'm so happy to be here. I'm Janelle Sokolowicz, as Taylor said, Associate Provost for Social Mission at Chamberlain University. In my role, I really focus on, as our university, we are the largest providers of nurses in the United States. We have over 13,000 undergraduate pre-licensure students across the country. And what we've been doing is really expanding our online pre-licensure program across the country to provide right now entry-level nursing education so that we can develop that rural workforce right where they are and where they live. So it's really exciting because it allows us an opportunity to serve that community and to keep those nurses there right in their community. As part of Social Mission, my goal is to make sure the students have all the support they need. We use a framework called our Social Determinants of Learning framework, which aligns with the social determinants of health. And we try to remove those barriers that any student faces in helping or preventing them from completing their degree. And so our goal is to make sure that we are creating right now health professionals.
Great. Thanks, Janelle. Brian?
Yeah, so thank you all for having me. My name is Brian Hodge, and I'm a family physician by training. And I also kind of define myself as being the father of 4 daughters, and that really actually does relate directly back to the work that I do on a daily basis. I think it is very purpose-driven to make sure that we have health professionals available in areas where there is the greatest need to provide better care and to close some of the gaps of the inequities as we see in our rural areas. So I serve, as Taylor mentioned, at MAHEC, which with the UNC Health Sciences at MAHEC, which is in Western North Carolina. We're an Appalachian region that is primarily rural. We have graduate medical education programs in the form of many medical residency programs for family medicine, internal medicine, OB, psychiatry, and surgery. But then we also have branch campuses for the School of Medicine, School of Dentistry, School of Pharmacy, and School of Public Health. And we really try to capture interprofessional educational opportunities that are not only going to be able to promote people going to serve in rural and under-resourced areas, but also have the skills to work as a team and to actually improve the health outcomes of communities. And so as a result of that, we also have a lot of pathway programs that try to identify people with varied backgrounds in middle school, high school, all the way up through the continuum of the pathways, and then supporting people that are actually care providers in our rural communities by making sure that they're networked and a part of something greater. So really appreciate the opportunity to talk with you all today, to also be a partner and try to figure out how we can elevate these voices, elevate these stories, and really demonstrate all the ways that rural is strong and has a bright future if the right things come into place.
Thanks, Brian. I need to correct myself. I said this is session 4. In fact, this is session 3. Emily?
Hi, thank you for having us. My name is Emily Hawes, as Taylor said, professor at UNC School of Medicine, health services researcher at the UNC Cecil G. Shep Center for Health Services Research, also affiliated with George Pink, who I think you recently heard from. Interestingly, I am a practicing primary care-based pharmacist doing chronic disease management in the mountains of Western North Carolina, very close to where Brian Hodges, and I am the only pharmacist in my community embedded in primary care. So I see on a real weekly basis the impact of health access. So until I started kind of providing intensive insulin management in our community, the local community members were traveling pretty far for those that needed to be seen by an endocrinologist. And so being able to serve patients in this area has made a difference for access to care. Most of what I do on a daily basis is help run 2 federally funded centers supporting the launch of rural physician and dental residency. And it is a joy to see the impact and outcomes from the rural residency planning and development program, as well as the teaching health center planning and development program that have been given startup funding to launch new residencies in these underserved settings. So we're supporting the launch of over 100 rural residencies through a plethora of partnerships, through tribal partnerships and FQHCs and rural hospitals within 44 states and 1 territory. So it's rewarding work to be a part of.
Thanks, Emily. So now I'd like to ask each of you to talk a bit about the challenges that you face in your work and how you're addressing those challenges. Janelle?
Yeah, in my previous role, I was vice president of a very large online program, and really worked hard to determine where their niche would be and understanding the impact and need for rural healthcare providers, specifically nurses. One of the big challenges we faced that I believe everyone on here would be helpful with is getting it out there. That we have a program that's available for students to participate in from their home. And that was hard to do, because when you think about marketing or that marketing impact in a rural setting, that can be challenging because there's so many different outlets. And we actually put together a pilot program where we used all of the local newspapers, and we picked just a small area in Tennessee, and we used just regular newspaper and little online blogs and the Patch, because I used to live in rural Tennessee, so I know the Patch, and also they use that in rural Illinois. And we were able to impact it, but it was difficult, to get it out there that we actually have programs available where people can stay home and still accomplish a baccalaureate degree in nursing or an advanced practice degree. The other part is the national kind of expectations for how we deliver nursing education. Specifically, many states have built-in barriers, actually against their own state in closing the shortage. We have states that require a graduate level degree to be the person that completes the clinical education, that is the clinical professor for the nursing student. But it's very challenging to find a graduate degree educator within a rural setting that may not have many healthcare providers at all. And so I have worked with many of the state rural health organizations to go and lobby with those boards to ask them to remove that and to have, you know, time on in their role and or expertise and or an assessment that we can provide to show competency so that we can start to build more, develop more health educators quickly, given what we have. And that is really important. I think you all would be helpful, right, to get that out there, that if we can create an alternative method to educate nursing students, and which we could have, you know, baccalaureate prepared nurses to oversee them, in many states that would help alleviate their nursing shortage almost immediately. So it's challenging. At the same time, you know, we know there's hope. There is a national nursing shortage and has been more significant post-COVID. But, you know, it's time for us to really start thinking innovatively as we can make a difference to over 40 million people, right, who live in rural America. So it's a big number that we have to impact, and we can impact, but oftentimes challenging with bureaucracy, policy, procedure, and things like that.
Great, thanks. So I want to remind everyone that you can ask questions and encourage you to do so, but please remember to type them into that Q&A window instead of into the chat. Brian?
Yeah, I can build off some of those wonderful comments from Janelle. And, you know, we really do look at the way in which workforce actually provides access, right? And I think that many of the inequities that exist in rural communities as far as health outcomes go can be improved by providing better access to preventative care, urgent care, primary care, as well as timely specialty care and hospital care. And one of the pillars to trying to train people in the right way is doing it in a place-based format. And if you're doing a place-based format, and you're trying to train people in rural areas to serve rural areas where there is already an existing workforce shortage, that becomes an immediate challenge for you. And so it's almost like you're trying to go build roads where there are no roads. And so I think you have to be creative, you have to be strategic, you have to create the right partnerships to be able to overcome those challenges. And, you know, I think that so much of the policy efforts will really focus kind of on urban-centric solutions that aren't always immediately applicable to our rural spaces. And when we look in our rural spaces, we see needs with respect to workforce, but also with substance use disorder, maternal child access, and behavioral health access. And so in Western North Carolina, we've seen 6 labor decks close their services to women, which actually then lent itself to several OB and family medicine providers of women's health actually leaving the region. And so then that's immediately limiting access and actually putting the burden upon our rural communities to who often have more social limitations to actually drive themselves, try to figure out how to have transportation to go 3 counties over. And so this has been a major challenge. It has gotten to the point also where I feel like we have to elevate, even though this is a reality that many of our rural spaces are poor, they're less healthy, they're older, and they're less resourced. That cannot be the pervasive identity of our rural places. These are also close-knit communities that can offer up a lot of innovative solutions and a lot of grit and community-based, team-based efforts that I think can help be a part of that solution. And so I think that we really have to think about how the reality of our rural spaces, how that narrative serves us in some ways. It outlines the challenges that are in front of us, but they cannot be the only story that's coming out of our rural places. And I feel like we all need to change that narrative together. I get particularly concerned when I see kind of generational impacts for a new reality being built in some of our most rural counties. Like Graham County is one that is kind of on the border of Tennessee and North Carolina, really an isolated community where they end up having some of the highest Medicaid spend rates because there isn't access to primary care. The families have just gotten in the habit at this point when they have issues, EMS is often called, and then that involves them being transported to another county for their care, which is clearly not going to be the best way to get timely care. And so there are probably a lot of basic things that we can do just to provide, some of the essential care that's needed for our communities that allows them to get timely addressing urgent issues like colds, cough, URIs, COVID questions, and do so in a way that they're taken care of by healthcare providers and a team that knows their rural issues and knows their community well. And I think that comes out of partnerships across specialties, across professions and disciplines, and in collaboration, obviously, with health departments and the resources and social community that exists in our rural areas.
Great, thanks, Brian. I wanted to point out that Janelle was having some trouble with her audio. She was breaking up some there, and so we've asked her to go off camera, but she's still with us. Emily, same question? Challenges?
Wonderful. So our data across these two federal programs shows that GME financing and faculty recruitment, so really building off of what Brian and Janelle shared, is the issue. It's the workforce, and having enough workforce to train the future workforce is the barrier. And so, but it's imperative that we build these programs in the communities where we want graduates to stay, because the research shows that those who train in rural, like Taylor said right at the beginning, are more likely. They're at least twice as likely. Some of the research studies show up to 5 times as likely to stay in the communities where they train. And so what I want to highlight is that what we're seeing in these programs, and I'll answer one of the questions that's been put in the Q&A, is that although there is this faculty recruitment issue to build the programs, that once the programs are built, those faculty and those graduates want to stay and then take on leadership roles within the program. And so these programs are really growing their own faculty and the providers for the community. I live in a community where we have a brand new family medicine residency that thanks to Brian Hodge, is in our community. And it's a small family medicine program that when the program was launched, we saw, a lot of people have said, well, it's going to take years to see the impact of these graduates staying in the community. But what we saw right at the onset of our program is that there's increased access to care because residents are providing services, right? Building the residency helped provide new clinical services like treatment for opioid use disorder, and behavioral health services, which is really important in the rural place that I live. And now a couple of your graduate classes, we have 7 of 8 staying in the community. And what I can say is that across all of these RPD, THCPD programs, about 60%, according to our recent analysis, are staying within the communities where they train. So I think we're going to continue to see this momentum of, although there are these real challenges around financing and recruitment, these rural health facilities are nimble and innovative and figuring out ways to address these issues, bring training to the communities. I think of Marshall University just this past year in Point Pleasant, a real rural community in South Carolina, started a rural psychiatry program embedded in a rural health clinic in a county with no psychiatrists. They figured out how to launch a program with no psychiatrists. So they're really kind of finding out ways to be creative and launch these programs. The other thing I'll highlight too is that what is so rewarding to just look over all these new developing programs is that they're training dentists and physicians to care for those that are underserved. So they're reaching into farm worker care. They're training their residents to go out in mobile units to care for that population. They're caring for the homeless, those impacted by incarceration. And so it really is this health equity that's driving the development of these programs. And, there are a large number of accredited programs through rural residency planning and development. We have 46 accredited programs. And then through the Teaching Health Center program, which is earlier on in the development of these new programs, we have 22 new accredited programs. So they're making a difference and getting launched successfully, getting accredited, and graduating residents and dentists and physicians to stay in these communities.
Great. Emily, you used an acronym, RTPTH.
RRPD, Rural Residency Planning and Development, and then Teaching Health Center Planning and Development. Do you want me to drop a link in the chat for folks?
Be great. Thank you. So you guys you've addressed this to some extent, but a little bit more on what gives you, what are your sources of optimism? What do you see can be done in this work with creativity and innovation? Janelle?
Yeah, I apologize for my Wi-Fi. We have a lot of storms here in Florida right now. Innovation is really at the key. I think a lot of it has to do with partners. Specifically for the nursing shortage, we have traditionally gone straight to the hospital to ask them to, take on nurses that may turn over really quickly, or have them help us figure out how to create their pipeline for their staffing. And I think that's where we have, missed the mark. We have really large, rural organizations that support rural America, like Dollar General, right? Family Dollar, that I believe we need to make connections with on building pipelines from their employees, creating an opportunity for them to offset the cost for their tuition. We need to make sure everyone has broadband so they can actually accomplish their degree. All of these large organizations, Verizon's and, AT&T's of the world, really to remove that digital divide that we know exists in many rural areas, creating some pathways for students to get access to hotspots, and an opportunity for them to have, just broadband internet so they can be online and accomplish a degree, and so they can change the life of their family and others. It's really important that we think about kind of the infrastructure that we have to build to sustain. So I think we have to get very innovative, very inquisitive, ask lots of questions, and think differently on how to do things. And we also may need to make alternative roles that have not existed in the past. In all of my interactions with rural health communities and rural nurses, I find that they are doing things that many nurses in your traditional hospitals in major metropolitan cities, teaching facilities aren't doing. They're taking on new roles. They're expanding themselves as both a leader and still a bedside nurse, which you don't see often in your very large organizations. And so I think we have to think outside the box on what are those pathways. One of the things that, we were thinking about and have discussed with other partners is developing a certificate specifically and relevant for rural nurses, so that those that may want to move to a rural area but may be afraid of community health nursing have an opportunity to be upskilled on how to do that prior to getting there, and to maintain that skill, because they do have to be able to be part of a true network of healthcare providers and work hand in hand with practitioners. I want to double click on what Emily was talking about, because we found the same thing with in a decision to expand to Kansas, we found a whole area of both Kansas and Missouri that had over 100 miles where there were no mental health services. And we built a psychiatric mental health nurse practitioner program specifically to answer that call. And once the state found out, they were super excited and supportive of what was being done and wanted to help in any way possible. It's really about using data and analytics to identify where the biggest need is and to determine these innovative strategies to reach those, like we did with the rural marketing pilot. So I just think there's an opportunity for us to think outside the box, to think differently, to not continue to bombard the healthcare system, but to really use those partners that benefit all of those residents that live within the rural communities.
Great, thank you. Emily?
Do you want Brian to go next, or do you want me?
Sorry, go. Yeah, no,
Yeah.
we'll keep it in the same order. Sure, yes, absolutely.
I was all for like
No, we've got plenty of time.
building off of what Emily has to say, but I've been very lucky to build off of what Janelle's been saying. I mentioned this earlier, like the things that make me most excited really are the proximity that shows potential in our rural communities. And so I think that the strengths of our rural communities were really showcased in, throughout the pandemic. We saw innovative solutions coming from those communities, banding together and doing things in a different way, working together through collaboration and through connections. And I actually really do have a lot of hope that is going to draw another generation towards those rural communities, because I think people are looking for that. They're looking to live in an environment where they know their neighbors and they have connections. And I think as a clinician or a health professional in those areas, it also lends itself into a lot of influence. And so when I met with a bunch of health professionals that were interested in rural health 2 weeks ago, we were talking about, what are the benefits of actually working in a rural area. And the thing that immediately came to the surface was, I know I'm making a difference. Like they can see their difference. And that is just so powerful for me. I think that there's a calling for those connections. There's a calling for those relationships. And I think the last plug is being kind of an educator and looking at this. I think that we recognize that there is ingenuity that can come from the younger generation. And so I think as we educate people in a place-based manner in rural areas, I think that they will not only be drawn to some of the strengths of rural communities, but they can be a part of actually bringing new solutions to the table and reimagining what the potential actually is.
I'll build off of Brian and saying both of us just listened to a resident panel of rural residents training in rural communities. And what came up was, why did you go to these rural programs? And one of the residents said, because I wanted to be more than a number. I am part of this community. I'm known. Our orientation didn't just include meeting hospital staff. We met the town mayor, the Chamber of Commerce, the principal of the local elementary school. My faculty member left me chicken noodle soup on my porch when I was sick. I mean, you are part of a community. And so one of the questions that actually we've been asked by policymakers is, why should we invest in rural residency development? Is there an appetite for training? Like, do students want to go to this? And the answer is, we have the data. We just published an article that you can cite. There's a lot of broad data that shows, yes, there's an appetite for rural training. So what we need to do is address the challenges in launching enough programs. There are not enough programs out there. And so what I want to close with, and it's a little long-winded, but I just want to celebrate the reporting and the impact of reporting. These national program, which we've been engaged with since 2009 at the onset of it, has been directly impacted by your work as reporters. And I'm going to share with two stories, one of which piggybacks off of us. Joyce just asked, do you have a link for the Marshall University program? And I'm happy to provide you the people to connect with. They're just so dynamic. They've started numerous rural residencies. And what I want to highlight is that we got connected with Melissa Stevens. Brian and I both did through Kaiser News. And Brian connected a resident that was able to share their story of how they've been impacted by training in a rural and underserved setting. And in that story, so not only as you are reporters are talking about the impacts and the joys and the rainbows and sunshine of it, you're also highlighting the frictions and the challenges, which are very real. And so what that Kaiser News article did, and I'll give you the article title, Funding Instability Plagues Programs That Bring Doctors to Underserved Areas. And that article featured Marshall University's Point Pleasant program that I just touched on, and other programs that were recently given startup funding. They've gone through all the steps of starting a program, attaining accreditation, figuring out some of their partnership models, recruiting a program director, but they were not given, sustainable funding to sustain their programs, which is called Teaching Health Center Graduate Medical Education funding. And so that article was published, and within, I think, a month of that article being published, highlighting that these programs were launched, but then some of them literally pulled out right as they were matching residents because they were not given long-term funding. Now these programs have a funding opportunity that has recently opened up. And I think part of that is reporting and you sharing these frictions on a national stage. And so thank you for that. The other, sorry, Taylor, I know I'm going long, but
That's good.
the other thing is I want to also touch on the importance of local news and the power of local news as well. And so one of the first rural residency planning and development grantees, St. Luke's Miners Memorial Hospital, started a rural psychiatry or rural family medicine program, 74-bed Medicare dependent hospital program. And what they noticed in the development phase is that they had inadequate projections for their Medicare GME financing to really sustain their program. And so they went to their local news and they shared about the inadequacy and really inequity that their rural hospital was facing. And so what that did, they told us, they went to their local stakeholders and policymakers, they told HRSA, they actually told a law firm who got noisy about it. And we were given funding to research this on a broader level. And so now we have it quantified. It's about to be published where each of these rural hospitals, sole community and Medicare hospitals, have less than $70,000 per resident FTE for each of their trainees. These research findings have been used to inform Senate Finance just in the past 6 months, Ways and Means, the GOP Doctor Caucus, and you may have noticed Senator Wyden's proposed GME policy change, and this specific friction and solution is now being incorporated into this policy change and in a proposed bill. So it is making a difference. Keep doing what you're doing. Thank you, thank you, thank you.
That's great. You could go on the rest of the half hour without Emily. Journalists like hearing that kind of thing. So please ask questions, put them in the question window. We're now going to go into our Q&A portion of the presentation, and I'm going to start with a question of my own. Now, given that we know that those who were born or trained in a rural area were more likely than those who weren't or didn't to go into a rural community. Beyond that, with that knowledge, beyond that, are there particular characteristics that you're looking at in determining if someone is a good fit to work in a rural community? And I'll put that out to any and all of you. Somebody,
I mean, I can start. I'm happy to speak to that. And I think you know, as much as it is ideal, I think in so many respects for people from a rural background, you know, to have the opportunity to go back and serve, that isn't always the case. And I think we're not going to be able to rely on that solely for building our rural workforce. So I think that place-based opportunities like Janelle is speaking to and Emily are speaking to you know, we have to open our eyes that like suburban converts and urban converts have to be a part of the solution. And I think that so actually talking about what are the characteristics or skills that are going to be best suited for someone to not only serve but also to serve in an impactful way. You know, we definitely want to train people in the way that they can meet the needs of their community, and so that is actually training for adaptability. That's training for compassion and empathy. That's training for you know, a lot of the most striking issues that are facing our rural communities, which would be substance use disorder, especially. And if I think back to it, when I was going through training 20 years ago, I mean, it is not the same environment that, you know, that we're currently facing with respect to treatment options for the opioid epidemic, fentanyl and methamphetamines as well. And so I think that we first have to train for the attitude and characteristic that you can adapt, that you can be resilient, that you can be engaged with your community. At the same time, we do want to make sure that our trainees in an interprofessional way know how to address the things that are pressing right now, which is why we've invested a lot of time and energy working on destigmatization programs for substance use disorder, as well as medication assisted treatment, especially for people that are certainly going to be caught in more challenging situations, whether it is a reentry program from being incarcerated, or people that are in that perinatal period. We know that there are, you know, these pivotal moments that treatment and access to treatment and surrounding people with resources are going to be most impactful.
thanks. Emily, Janelle?
Yeah, I want to make sure you can hear me. You can hear me okay?
Yes, can.
All right. One of the things we look for, and one of the things I found historically, having been in higher education close to 2 decades, is we find specifically in rural areas where our nursing students have a history, a story to tell, and they're part of the community already. So maybe it's the nurse's aide, or it's the, you know, our average age is 35 in our programs. And so our students have family and friends and a church and all of those things. They have roots, right? And they've already demonstrated grit. And just like Brian was saying, they're gritty. You know, they understand the dynamics of living in a rural community. They understand the importance of the stability and also oftentimes instability of the workforce and job market. And so when they get the opportunity to do something like be a nurse and be at the bedside, we want to find that person who wants to work to the highest level of the degree that their state allows and pushes to do that to service their community. And we find those that have a family, that have, you know, family members they're caring for, that have those roots already built, do really well and stay and grow and take it on themselves. I can't tell you how many I've met who became faculty, but they started off as a rural nurse. They now own, you know, they may be faculty online, but they have another business that they do and they provide mental health services to their community. And so I think that grittiness is really important. I'm glad you asked that. The one thing I didn't get a chance, I wanted to come back so I could be heard, but to make sure that the connection was well. So some people know, some people don't realize that nurses, undergraduate nursing, even though we know we have a national shortage, does not qualify for the graduate medical education reimbursement. And that is one of the reasons for the shortage, is because the hospital does not have any gain per se. They really take on all the risk, right? About $40,000 to onboard one nurse. And then many times they'll turn over in under 2 years. And so you think about that, that's a significant financial responsibility for a healthcare system that may already be threatened financially. And so, you know, what we can do from a journalism perspective is to advocate for policy around the graduate medical education credit. It is a historic thing that was done for physicians and nurses, although we are on the Hill and I'm one of them and we're fighting constantly supporting legislation. Our physicians have a very tight arm on that. And so it's just important that we put that out there, that if there was some opportunity for the healthcare systems, it would help to decrease the burden and increase the nurses that are available and you know, to kind of solve that gap.
I want to build off of what Janelle said about roots. What our data show is that those that have rural roots, or, you know, even roots within the same state or region, are what a lot of these programs are looking to recruit their physicians and dentists. We just evaluated all of the applicants of rural and FQHC based or federally qualified health center based residency programs across the nation, and they have a higher number of international medical graduate applicants, higher rural background graduates, and then higher osteopathic or doctors of osteopathic medicine, DOs, which Brian, I believe you are. And so versus allopathic doctors. So those are just some of the findings that we recently came across. But I do want to highlight there is an article, and I'll link it soon, that was recently done in the past 2 years that shows that regardless of urban or rural background, which Brian was highlighting on, the most important predictor in future rural practice was rural graduate medical education. So it's that place-based training that actually has a greater impact on future practice setting.
Great, thanks, Emily. So we're going to go to you guys' questions now, and let me. I want to urge. We got a bunch of questions here. Happy to see that. I just want to urge panelists, if you let's keep your answers as compact as possible, so we can get as many of these in as possible. There's a question for you, Janelle, about how you're using media to get your message out, how you're using, you know, newspapers, blogs, social media.
I can't see that question because I went out and back in. So can you just actually say the exact question?
The question is, what kind of promotion you make through newspapers and blogs to promote better care in rural areas? Do you use social media too? What kind of new marketing are you planning to innovate and to develop better delivery of nursing education?
Yes, we use social media as well. We used, you know, newspapers as well. And the goal now is to partner more closely with those smaller newspapers that may service directly. And I'll tell you why. You know, having lived in a rural area in Tennessee, you know, everyone read the little patch that comes on Facebook, the patch, but it also is a paper and it would come out quarterly, but it had who had been arrested. And so everybody still read that paper. So although they were adults and you would think, oh, they're in their 20s, they're not reading that, but they would, because it would have the list of who was arrested. That tend to have, when we did this pilot, it actually was a better lift for marketing and contact, letting people know. Journals, that's another way we're looking at specific journals. And then the biggest way I think that we can help, when we first decided that this was going to be a strategy to move on, I actually went to the national hospitals, the National Rural Health Leadership Conference, and it was in Phoenix, and there were absolutely no health education entity present. So although it was in Phoenix, Arizona State's there, all of those schools are there, they were talking about the shortage, but there weren't any health education. So for me, that's the way that we're planning to connect with those national rural health organizations to really get the word out there that we're available, we're ready, and we're positioned to support developing a high quality workforce.
Great, thank you. There's a question, apparently a speaker in session 2 said it's hard to pay enough to keep staff in rural hospitals. Long-term, what fraction of your trainees stay rural? I know, Emily, you talked about, you've had the success you've had. You other guys, something you want to comment on, and perhaps to what extent, or how often pay becomes an issue?
Yeah, I mean, I think, you can go chasing this with money, but what we're really talking about, and I think this is the narrative that can help support that is, we want the rural practices and places that people receive care to actually be in a model that is going to support them sustaining their business. And so we see labor decks closing, we see rural hospitals closing, we see rural practices closing, we see rural pharmacies closing, and it's because in so many ways the deck is stacked against people, and that does go back to our reimbursement models. And so I think if we speak in generalities about the demographics, there are going to be higher rates of Medicare, higher rates of Medicaid in these populations, and I think that will directly speak to how well clinics are resourced to sustain keeping their doors open. And so I think that yeah, so we really want, it's actually not always the highest paid position that attracts someone to go to a rural area or to stay in a rural area. The most successful places that I've seen have actually had lower salaries, but a bigger sense of autonomy, community, and that's been really attractive to people. So I think that it's part of something to consider, but I don't think we're going to pay our way out of this.
Janelle, you look like you have just a quick comment to add to that.
Pay tends not to be usually the issue from a nursing perspective. They normally are able to stay relevant. It's more of, you may have lived in that area, you left, and now you're coming back. It's, adjusting, because many times we can't educate the nurse within their community. And so they're having to move back to that community and then adjust to that change in pay.
Great, thank you. Question to anyone on the panel: is there anything that medical schools can do to encourage future doctors to choose primary care and rural care? Maybe Brian?
Yeah, and then I'm sure Emily and Janelle may have other things to say. So I think there's a lot of things that could be done. I think, especially for state institutions, I think there should be some level of social accountability for their graduates actually serving the state that's supporting that educational system, in a way that makes sense for them. And so that's going to be developing programs that will incentivize a path either through scholarship or through a track that can really try to encourage people to be considering jobs in the state in under-resourced areas. And so I think also admissions needs to be called into account as well. And so making sure that, they're recruiting people that have the heart and the mind to do this work. And so I think that those are key variables. There are some innovative programs out there. I think at UNC, we have an accelerated program that's a 3-year medical school with a commitment to a in-state residency program with an additional incentive to practice in-state in a rural or under-resourced area. And so I think there is some level of innovative programming out there, but the dose is just way too small. I mean, we're talking 5 students a year. Like, that's not going to be nearly enough. We need to probably quadruple that at least to actually start bridging the gap that continues to widen. So like when you look at the workforce numbers as far as supply and demand goes over the last 40 years, the gap is actually widening. So less and less people are going to rural areas. It's more and more deprived as we move forward. So I often think like if any state institution just, you know, incentivize primary care and rural health clinicians for like 5 years straight, every graduate ended up doing that, we still wouldn't be caught up. And so, but I think we would be much better off than where we are right now. So I hope there's some sense of accountability with those things.
Accountability metrics. I'd like to highlight only 2% of residency training across the nation is in rural areas. So we need more rural residencies. The other thing that we recommend to those health facilities that are more fragile and may not be ready to launch a full-blown program, we say, hey, consider hosting a resident for a rotation or students, because that can impact future practice.
Great. Thank you. Question again to anyone on the panel. Increasing the workforce shortage requires a long-term committed plan. What can be done in the short term? Also, considering the risk of burnout, if the answer is asking those working to simply do more.
You know, there was a really great partnership with a teaching hospital and a rural community hospital. And I think, and it was a virtual relationship. So they built connectivity where they could do virtual NP visits, and we could complete our clinical hours and training virtually. So the student could provide kind of the video, evaluation and support, and all of the nursing evaluation and medication administration. And then those partnerships are really important because you're exactly right. It's still really lean. Some of the things we're talking about are going to take longer to do, and patients and their families are being impacted today. So how do we do that? I believe there should be very tight relationships with these large university medical centers who have a lot of money to be required to partner with rural hospitals and rural organizations so that they can cross-train and also cross-support. So whether that's, using technology so you can do a virtual assessment, whatever it may be, they need to be responsible if they've been given that much, if they have that much financial ability to, expand and build football stadiums, they should be given the responsibility to host and support 5 to 7 rural healthcare systems around their surrounding area, right? Within 100 miles of them. Because I think that is where the rubber meets the road and the money makes sense. We are really putting our money and all of our effort into the wrong basket at those larger institutions if they're not willing to commit to partnering. And so those are the ways I think we can make a big difference in the short term while we're still building that workforce.
Yeah, you hit that on the head right there. So it's how do we get more? I mean, get more from the existing workforce is we support them better and we incentivize them to work together and collaborate more. And so I think that has to be a shared effort across the board. So.
Great. A question for Janine about working in or with compact states, or if it's easier versus non-compact, and maybe you could
Yeah.
comment by explaining what that means.
Okay, so for your nursing license, we have states that are within, they've all agreed to have the same requirements for nurses so that the nurse only has to apply for a license one time to practice in said states. It's over like 35 now, but not all the states. And so some states are within that compact. So you only need your nursing license. And then when you move to another state, you just transfer your license. You don't have to do anything else because you can immediately practice because you're under a compact license. Florida is one of those states. Virginia is one of those states. Washington, D.C. is not. It really depends. Some states are more amenable and they tend to not have those existing rules. What we have found in our research is that states that have a very, very strong community college system that already creates associate's degree programs, they really want to keep all of their money in state. And so they kind of set the rules. And they can make it very difficult for those who are trying to do things either at scale, remotely. We have 13,000 undergraduate pre-licensure students. Most nursing programs are graduating 30 students. And so when you have a 2 million nurse shortage, that is not going to it's like a drop in the bucket, the same as what Brian and Emily were saying. So it's like a drop in the bucket. I mean, it's like 30 people and you have all these patients. So that we have seen it happen in some ways. I will say, Washington State probably is the most rigorous, and behind that is California. And so when you have very strong state community colleges, they tend to be really rigorous and have a lot of rules that would benefit their state internally, but it makes it very difficult for those who are trying to provide education at scale with a standardized curriculum across the United States.
Okay. Anybody want to add anything there? So, okay, we've got a question about paramedics and whether there might be a greater role for paramedics in rural communities to take on other responsibilities.
Emma, you can go ahead first.
Yep. I don't have a great answer to that. I just,
We have a lot of community paramedic programs that have looked into this, and it has been, I think, a viable solution for some communities. And so specifically that the Graham County one that kind of had that element of very limited primary care access and urgent needs from the community not being met. So I think there are definitely roles for that. Community health workers are another workforce that's emerging as a really potent solution for actually promoting healthy behaviors and those types of things, and getting people connected and navigated throughout a health system that isn't always serving them. And so I think that we have to, develop local solutions based on assessing the resources around us, and certainly paramedics, community health workers. I think that they are real good strategies to try to better utilize the workforce that we have.
So during the pandemic, there were a couple states. I know specifically Wyoming. They did a mass training of almost every paramedic to take on many of the nursing duties during the pandemic. So it has been done, right? When you're under pressure, you innovate, right? And so we can innovate pretty quickly. I think the thing that we can use you all for is to help to elevate the pressure. Because under pressure, we innovate, and under pressure, we respond. And that's why it's important that you all keep the pressure on this topic, because the more pressure, the better response, and people tend to react, and then we move quickly. We saw it in the pandemic. And so we know that it can happen. We know people can create a vaccine quickly. We know that things can happen a lot faster under pressure. And we're going to use your voice and your ability to articulate well to continue to apply that pressure.
Right. So we've got just a couple of minutes, maybe a minute and a half. Brian, I did want to ask you, though, about substance use disorder and how you can help prepare young health care professionals to deal with SUD in a rural community.
Yeah, and so there are very few individuals in rural communities that aren't directly affected, and so I think working through destigmatization, opening up the doors for kind of no wrong entry, so that treatment is available. I think often can and should be occurring in primary care settings, especially in partnership with pharmacists and nurses and community health workers. I think that treatment alone is not enough. I often reflect upon how, what is the root cause of substance use disorder and overdoses. And so many times it's actually a vacancy and void of a sense of community and purpose. And so I think that there's, despite us opening up access to treatment, we aren't necessarily proportionally seeing the outcomes that we really desire and are needed to fully show that we're bending the curve significantly. And so I think that's gonna occur, in partnership with community, through building relationships and making sure that all health professionals, that they're not we are not in the setting or in a system where we're just training people to be a widget. We are actually training people to care, and training people to make a difference in people's lives really requires you to build those relationships and train in a way where they're prepared to meet these challenges.
Great. Thank you so much. Thanks to everybody. Thanks for everyone for coming.
Thank you, Taylor.